So as mentioned, I am Rachel Mutra. I'm the director of the Missouri Telehealth Network and of our Show Me Echo program. I'm trying to turn something off on one of my screens. I think I might have turned on subtitles or something. Oh, great.
I'll see if I can fix it on our end.
Okay. I'm going to try not to look at them while they're still going. Our program, the Missouri Telehealth Network, started back in the mid 90s, and it's changed a lot over time. But at that time, the federal government was really interested in learning more about how the internet could be used and about telemedicine. And the federal government was encouraging academic medical centers like ours to explore the use of telemedicine between two different healthcare entities, like hospital to hospital. So since then, we've gone through many different types of telehealth projects. And a lot of what we do these days is to train people on different telehealth projects, including helping people start their own telemedicine programs. We do have trainings and conferences. We partner with the state on many different projects. We have funding from our state. We have funding from the federal government. We have contracts with different types of organization, and we have grants. We started the Show Me Echo program back in 2014, and we'll talk a lot more about that today. Our federal funding, though, is through HRSA, if you're familiar with HRSA. And the project that we have is called the Heartland Telehealth Resource Center. And this project is in partnership with Kansas and Oklahoma. And in fact, KU Med Center is the PI, and they have been since the inception of this project. We've been partnered with Kansas on this since 2010. It's a really great partnership. And the purpose of telehealth resource centers is to answer any question that people have about telehealth. We're non-biased, and we don't cost any money. We get our funding from the federal government. So anybody that needs some advice or information about telemedicine, they can give us a call and ask us any question. Now, the mission of the Missouri Telehealth Network is to develop, study, and use telehealth solutions that improve access to care by providing high-value, patient-centered healthcare and medical education in Missouri and beyond. I'm going to do one little definition for you, just so we're on the same page here. When we talk about telemedicine, we talk about when a patient and a healthcare provider are separated by geography. They're not in the same place at the same time. Sometimes that care can even happen at different times. It can be asynchronous care. When we talk about the word telehealth, we use it more as an umbrella term that does include direct patient care, but it also includes medical education. It includes training. It includes a whole bunch more things than the direct care of a patient. And the project that we're talking about today, which is ECHO, does fall under the umbrella of telehealth, but it is not direct patient care. There are no patients in the room when we talk about an ECHO program. So ECHO stands for Extension for Community Healthcare Outcomes, and it is a model of education and training where the aim is to democratize knowledge, increase capacity, and provide best practice care. It's a hub and a spoke model that uses a knowledge sharing approach where people with more experience get to mentor people with less experience. People who are specialized get to mentor people who are more generalists. And the hope is that you're going to build a community of practice where there's trust, there's a shame-free community where anybody can ask any question. And the point is to reduce the disparities in care and create lasting professional and social networks. Now, ECHO stands for Extension for Community Healthcare Outcomes, but in Missouri and other places, it has definitely spread beyond healthcare, certainly into education. And in fact, I heard at a meeting last year that they're going to try to make ECHO, it's been an acronym for about 20 years now. I think they're going to not take the acronym part away and just call it ECHO so that it is more inclusive of other types of programming. Olivia, I saw you nodding your head. Did you think that you heard that rumor too?
I haven't heard that rumor, but I agree with that decision because I think, especially since we have some education people here on the call, ECHO seems very medical. And when we have healthcare outcomes even in the name, then it seems to almost exclude those in education when this platform can very much be used for education as well. So I just agree with that change.
Great. We'll see if that happens. So the way ECHO started was with this person that's on the screen right now, Dr. Sanjeev Arora, who's a hepatologist at the University of New Mexico in Albuquerque. And back in the early 2000s, he, among the other diseases that he saw hepatitis C to be able to cure people with the new treatments. Well, he had an 8-month wait for people to get into his Hep C clinic. And as all of us know, waiting 8 months to get in to see a doctor is a really, really long time. And during that time, people would get much sicker than they were before they, decided to get treatment. In some cases, it was too late to get treatment for their disease progression. Instead, maybe they already had liver cancer or liver failure and needed a transplant. And he decided that it was such an untenable situation where there were only 2 places in New Mexico that were treating Hep C. This was a disease that primary care providers were not treating at all. And he wanted to be able to partner with primary care and train them on treatment of hepatitis C so that people could get treatment quicker. So he pulled together an ECHO hub team, and it was an interdisciplinary team. And I will let you know that the treatment for hepatitis C at the time was a lot like a chemotherapy. So it made patients sick. In about 50% of the patients, it also caused pretty severe depression. And so if you're already sick with a terrible disease, you have to drive many hours to get your treatment. And you had to go, at the time, the treatment was about 10 months of treatment, and you needed weekly treatments. So going a long way over a significant amount of time and made to feel sick at the time, a lot of people were dropping out of the treatment. And so they would end up not getting their hepatitis C cured. So he went around the state and he put together his hub team. Then he went around the state and asked people if they were willing to treat Hep C in their own clinic, if he would be willing to train them and mentor them. And he got about 20 different providers that said yes. And they started meeting every week over video conferencing. And every week they would provide a short didactic or lecture. But most of the time they spent together was spent in case-based learning, where those providers that were on the call would talk through the different data points about their own patient in a de-identified way. And then they would discuss together different questions about those patients, and then they would make recommendations about the care. So in hepatitis C, it's a little bit like a recipe or a cookie cutter approach, I would say. So there were 20 different data points. So it would start something like, I have a 45-year-old patient who is a white female who contracted hepatitis C through a blood transfusion that she got after a car accident. 15 years ago, she didn't know she had hepatitis C until recently, and they would share those types of data points. And after that, there's a whole discussion. But at the end of the day, those primary care providers would get direction on how to treat that patient of their hepatitis C. And Dr. Arora studied the outcomes of the patients that were treated by primary care against the patients that were treated in his clinic. And the outcomes were basically the same. In fact, in certain types of hepatitis C, the outcomes were better among the primary care group. And they posited that the outcomes could be better because the patients got their care closer to home by providers that they know and trust, instead of going to a faraway place with providers that they didn't know. So the good news is that it worked, and since then, ECHO has been expanding all around the globe. And so right now, there are at least 62 countries that use this model for education and training. There are over 5,000 different programs, about 1 million different learners within the program. And here in Missouri, we do show up on that map, but North America has so many dots that you can't tell. I will tell you that every state in the US has at least one ECHO program, and Missouri is no different. When Dr. Aurora talks about the ECHO program, and especially when he first started it, he separated ECHOs from telemedicine and separated ECHOs from just normal webinars. And he had 4 key components that made ECHO different. Now, here at Show Me ECHO, we've added that 5th component. So the first thing was that we're going to use technology to leverage scarce resources. In other words, we're going to amplify how we are training and educating our existing resources. So the scarce resources in this model are the knowledge and experience that are in the brains of the people on the hub teams, and the knowledge and experience that are in the brains of all of the spokes, all the participants. By getting together, we can share that knowledge. The second key component is the sharing of best practices to reduce disparities. And you all may recognize that in medicine, best practices are not always used. And in fact, even when a new best practice comes to light, it's several years before best practices are adopted by different types of healthcare professionals in different areas of the country. And a lot of times I like to say evidence-based practices. However, a lot in medicine is not evidence-based. And an example of that is in child psychiatry. All the medicines that are used in child psychiatry have not been shown effective in the sort of the gold standard of studies, because we don't do drug trials on children. That would be unethical of us. So instead, we use best practices. So we try to make sure our language matches what we're doing. So we do say best practices. In a lot of our ECHOs, we do use evidence-based medicine, but not in everything. The third key component is use of case-based learning. And we know that adult learners learn best by learning by doing, by practicing things and learning over time. When Dr. Aurora talks about this, he talks about learning to drive a car and how complex it is to drive a car. So you would never just read a manual and then take a test and then have the ability to drive a car. You have to practice over and over to get good at it. Now, the O in ECHO is for outcomes. And for us in Missouri, that means that we really want to study the effectiveness of the program. And are we really teaching anyone? When we teach people a new best practice, do they adopt that best practice and use it for all of their professional work? Or did they use it just for one instance and then never use it again? And those are the types of things that we evaluate in our program. And finally, the 5th key component is creating a community of learning. And we have some people that work with us that will watch ECHOs, and they will evaluate them and grade them on different things that would show whether or not an ECHO seemed more like a webinar or seemed more like a community of learning. So a couple of things in that might be, does everybody talk? Because in a webinar, like what we're doing today, I'm the only one talking. But in an ECHO, we want to see everyone coming to the table and being able to ask questions and give their recommendations while we're on the call and be able to share their own cases. So we are looking at communities of learning and measuring whether or not our ECHOs are successful in creating them. This slide just quickly shows the difference between a telemedicine visit and an ECHO program, especially in terms of the reach. I am a person that has worked on telemedicine projects for more than 20 years, and in my mind, telemedicine and echo should go hand in hand. And an organization like the one where I work, University of Missouri School of Medicine, should offer telemedicine visits alongside offering educational programming like echo programs. But for a person like a physician who has limited time and they're trying to reach a lot of patient outcomes, then an echo program reaches a lot more people than a telemedicine program does. And you can just see that through that graphic. A little bit more about hubs and spokes. And at the beginning, I didn't ask everybody how much echo knowledge you had already, and you might be experts in echo. And we'll talk about that when I get finished with the slides. We can ask people how much they know about echo. But if you think about how the echo hub and spoke model work, we want the subject matter experts, so those people on the hub teams and who are interdisciplinary. We want them to be able to share their knowledge and facilitate a learning environment. We want participants to come to learn new skills and be able to practice those skills and talk about it. We want them to gain confidence in their new skills and new knowledge. And we want them to fully engage and join that learning community. And then the outcome of that should be that the community members where the participants live are now able to receive advanced equitable care sometimes without having to go to a city to see a specialist. And in the case of Dr. Aurora's hepatitis C clinic, he was able to reduce the wait time in his clinic because before he started the echo, there were only 2 places in New Mexico that treated hep C. And even after that first year, there were 22 places in New Mexico that treated hep C. So you can see how the echo model works to increase the capacity of healthcare. I just wanted to show you a couple pictures of our hub teams, and we don't put them on our website like this anymore. We used to do pictures of everybody so people could see who was on the hub before they joined. But the purpose that I'm showing you, of me showing you this, is to show you that the Missouri Telehealth Network at the University of Missouri, we have a lot of specialists here. We've got lots of different people that work here, but we don't rely on only people that work here to fill up our hub teams. And the reason we do that is quite simple. It's because we know we want to hire the best people to fill that role wherever they work in Missouri. It doesn't matter if they work in Columbia, Missouri, or Kansas City, or St. Louis, or Springfield, or anywhere else. And I sometimes have a slide of where hub team members come from, but I don't know if I have it. But just know that if you're thinking about an echo and you're wondering, is this a real, University of Missouri centric project? It is based out of the University of Missouri, but again, we hire our hub team members from wherever they work in Missouri. The participants in the spokes, we always want more people to come to our echoes. Our echoes are designed for professionals, though. They're not designed for lay people necessarily. It is professional education, it's professional development. And we don't have any of our echoes designed to go directly to families who are being affected by whatever topic. Not yet. That's something that we have thought about for a long time. We just don't have it right now. So we do want more spokes, we want more participants, but they really need to be professionals. We want them to come and attend the sessions and participate in the sessions and present their own cases. And we like them to turn their camera on. That's something that we've struggled with, especially since the pandemic. Because everybody's so used to being on video, they're like, I'm just going to leave my video off. Now, I had mentioned a learning community before, but the definition of a learning community is that these are groups of people who share a passion for something they do. learn how to improve through regular voluntary interaction. And this group of people are there to support individual and collective learning. They're non-hierarchical. In fact, for our Show Me Echoes, we ask that people use first names only, so that some of us are not doctors and some of us are doctors. We're here to share the information among the community and to build trust and to foster the expression of diverse perspectives. Now, when you're in an echo session, typically the first part of the echo session is a lecture. And sometimes we call that a didactic. There's a whole bunch of other terms for that, like a mini lecture, knowledge bursts, and other things. But the first part of the session is didactic. It's not always at the beginning. Some echoes choose to have that lecture at the end of their session. But either way, it should take up about 25% of the time of an echo session. The rest of the time should be spent on cases and recommendations. And so what typically happens is that a participant would send in a de-identified case, and they do that all through a link on the internet. And then people on the hub team review that case prior to the echo session. And then during the echo session, that participant presents their own case. And there's a very specific way that the discussion is facilitated after that. And you can ask me more questions about that in just a few minutes if you have them. We have looked at the different benefits of the ECHO model, and there are lots and lots of them. And when we talk about the benefits, sometimes the benefits are to patients, sometimes they're to providers, sometimes they're for teachers or school administrators, sometimes they're to the whole community, whether that's the education community or the healthcare community. But these benefits that I've listed here are just a sample of the benefits that we could think of for using the ECHO model and expanding the ECHO model. Now, the ECHO project that I've worked on for the past 10 years of my life has been really, honestly, the best project I've ever worked on, but it doesn't mean that it doesn't have challenges. Carving out time for busy professionals to attend ECHO sessions is really hard. Whether you're an educator or a healthcare professional, it's just hard to take time out of your day and make it happen. And most of our ECHOs are twice a month for 1 hour. So that's 2 hours a month. That doesn't seem like a whole lot of time for professional development and education, but it's still hard. We try to do our ECHO sessions mostly at the noon hour because that seems to work the best. And still, people just hate it that it's at noon and they can't seem to make it there on time. We also have a hard time getting the right participants for an ECHO. So some of our ECHOs have very specific target audience, like our community health worker ECHO is just for community health workers, really. That one, we do get the right participants. But for some of them, particularly, I would say hospital-based echoes, it's really hard. So we had an echo called newborn care echo, and it was for sick babies. It was for people who care for sick babies. And getting hospital-based personnel to come to an echo is really hard because if you work a shift, whether that's a 12-hour shift or an 8-hour shift, it's hard to take time away from that, away from caring for babies in this case, to go do an educational program. So that is a challenge. It's really hard to get participants to submit their own cases. We think that it's a pretty high bar to come into a group of people and tell them what you're having problems with in your professional life and where you might need some help, especially if you don't know those people and you don't know, what they're going to think of you if you're bringing a case and you tell them you don't know exactly what to do. Finally, one of the biggest challenges we have is articulating the benefits of ECHO for organizations so that they would support their own staff and personnel to join more ECHOs. So articulating exactly why they should give those folks, 2 hours every month to come and join an ECHO has been a challenge for us. Just a little bit of information about what we do here at Missouri Telehealth Network, what our team does. because we try to make our echoes seem like they go off without a hitch every single time. And I will tell you right now, we typically have, I don't know, between 12 and 20 echoes every single week. And these are all of the things that we do here in-house to make it go smoothly. And we've got a few MTN staff on our webinar today, and they can tell you more about that in a little bit. The funding for Show Me Echo comes from 3 sources for the most part. We have a state appropriation that we've had since 2015. And so we get an amount of money every year from the state to spend on echo programs. Since 2018, we've had contracts with the managed Medicaid companies. In Missouri, there are 3 organizations that have the main contracts for managed Medicaid, and we have contracts with each of those organizations to help fund our echo programs. And we also utilize grant funding. And when we see that there are grant opportunities available, then we will put together a team and apply for funding for those. As previously described, the funding goes to support the hub teams. Actually, I didn't describe that. I'll do that. So the model is when we put a hub team together, then we pay part of their salary so that they can be an expert on that hub team. So we use them more or less as a consultant to help come up with the lectures, to help stay organized for every echo session, to help plan for future echo sessions, to help recruit for echo participants. And then the other 2 buckets of where does the funding go are for MTN operations and the evaluation of our program. When we choose new echo topics, these are sometimes people ask this question. So we made a slide on it. And basically, there are 3 different ways that we think about choosing new echo topics. One is that we have a funder that requests it. For example, in the state legislative language for our state appropriation, they put right in there that we had to do a Hep C echo and a pain echo and a couple others. But so those are ones that we have to do. Several years ago, the Missouri Foundation for Health came to us and said that, you know what, you guys really need a suicide prevention echo because the suicide rates in Missouri are higher than they need to be. And I think that an echo would help with that. So we started that echo. They also came to us and talked about foster care. So we started a foster care echo. The second way that we would think about choosing new topics are to look at the public health data. So cardiovascular disease is the #1 killer in Missouri. And so we're currently in the process of starting a cardiovascular echo. And then finally, a lot of times people come to us and they describe to us what the practice gaps are. So many years ago, folks from here at our university in the Asthma Ready Communities program came to us and described the gaps in knowledge related to childhood asthma. And we've been doing a childhood asthma echoes ever since then. So those are what we're talking about. Echo can really address gaps in knowledge when providers choose to come to it over time and gain a lot of knowledge about that topic. When we start a new echo, we really need to understand what is that gap. We need to know who is the target audience and therefore what types of experts are needed on the echo team. And then, of course, if we build it, will they come? I just described to you that we had a hard time getting people to come to our newborn care echo because they are hospital-based folks. And in fact, we decided to sunset that echo because we couldn't get enough people coming to it. And you can imagine how frustrating it would be to have this project that you worked so hard on and you have built it, and then you're getting a very small audience. So we sunsetted the newborn care echo recently, but we hope to bring it back in a different form where we can get a bigger audience. You can see this list of echo topics on the showmeecho.org website. And this one is not quite up to date. For example, it probably still has newborn. Yep, newborn care is still on there. So this one isn't exactly up to date, but it's pretty close. So you can see we have lots of different topics. Many of them are in healthcare, but there are some that are not directly healthcare. And we're always open to talking about new topics with anyone. I know you guys are looking at this. I'm going to go ahead and go to the next slide because you can look at our website if you want to see that. Oh, I talked about this. This is not up to date. So if your own organization is not on there, please don't be offended. This is an old list, a partial list of organizations that we've partnered with over the last 10 years to build hub teams. But it's certainly not all inclusive. The point of this is for you to understand that, again, we're not just relying on folks from here at the University of Missouri. We're going all around the state to find the best people wherever they work. This nice map shows that we have touched every single county in the state with learners from all of our ECHO programs, but we really need more participation from all of our counties, really from all of our counties. These two graphs show basically, that we've more than tripled the learners over the past several years, but we're still trying to really grow how many learners that we get. And you can see last year in 2023, we had about 3,500 learners show up on our ECHO sessions for more than 18,000 person hours of instructions. And we had 585 ECHO sessions last year, and we're really proud of that. We measure satisfaction rates of all of our ECHO programs, among other things. This is just one of the things we measure. But for the most part, we get really good feedback on that people like ECHOs. So people that come to ECHOs, they like the ECHOs. We do need more people coming to the ECHOs, though. I think in this survey, we probably had, and somebody correct me if I'm wrong, but I think we had about 350 people take this survey. So it's a pretty good sample size, but it was still less than 30% of our goal of participants to participate in the survey. This map is kind of cool because we said we had 585 sessions. We had 497 cases though last year, and those cases represent a large part of rural Missouri, and that's really exciting. So I want you to think about the fact that each one of those cases was a real person, and their healthcare provider brought their case to an ECHO session, had a discussion about their case, and were able to go back to that family and talk to them about what they learned and maybe new things that they learned or new things that they could try. And I think that is my last slide. This shows our website. You can register at showmeecho.org. And I'm going to stop share.